Okay, are we seeing good stuff now?
No, we can still see that, just that one web page.
Sure.
So normally when I hit the green share button at the bottom, if I have the PowerPoint open, it'll come up as one of the options, and then I just select that as the option to share.
My apologies. I didn't think I would have this much trouble with this.
Yes. So now we see your email.
Okay, perfect. How about this?
Perfect. Now we see the slideshow.
Okay, great. Sorry about that, guys. So again, this is Logan Thomas, a research analyst with the Appalachian Regional Commission. And today I'm going to, thanks for the invitation. I'm happy to share these resources and this information as often as I can, as much as I can with as many people. And so this is I'm going to provide an overview of this research project that completed just earlier this year, actually, but it was a years-long process. And ARC worked with a couple other partners, Robert Wood Johnson Foundation and Foundation for a Healthy Kentucky. And the goal of the project, what I'm going to talk about today, was to do several different things, 3 separate components, look at health disparities in Appalachia and compare them to the health conditions in the country as a whole. And also we like to look at, when we're doing stuff, region versus the United States, also then within the region, so how does health performance vary within the region? So we do that first, and then based on that, we identify bright spots or counties throughout the region that have better than expected health based on their characteristics and resources. So it's not just the top performing counties in terms of these health indicators, it's the counties that are doing better than we would expect given what's available to the local residents. And then after that, the third component is 3 issue briefs. So we looked at 3 particular issues throughout the region that are particularly impactful in terms of overall health, obesity, opioid misuse, and smoking, which of course ties in with COPD and lots of other health issues. And I'd also, and as part of this, we created the healthinappalachia.org, which is I think a treasure trove of information for practitioners and stakeholders throughout the region interested in health in the region, where you can go, you can play around with all the data that are in the report, you can find them there, all of the case studies, all of the issue briefs, all of the strategies and recommendations, links for communities throughout the region to go to browse through, find out whatever you're interested in. You can click, you can just focus in on that because the report is huge, as I'll get into, but you can really narrow down, both the theme you're interested in, whatever the health issue might be, and then also the geographies you're interested in. So particular counties, if you're just interested in, I grew up in Allegheny County, Maryland. If you're interested in Allegheny County, you can go look at all the health variables for Allegheny County, Maryland. Just how we define the Appalachian region as the commission is, it spreads across 13 states, there's 420 counties. All of West Virginia is in the region. It's the only state of those 13 states entirely within the region. 25 million people, so it's about 8% of the U.S. population, and we break it down into 73 local development districts, so kind of cohesive units throughout the region, made up of multiple counties that kind of work towards local development at kind of the small scale level. And and how we view a lot of things, and just kind of give you an overview of where Appalachia is socioeconomically, which won't come as news to most of you. We compare Appalachian counties versus the U.S. as a whole, every county, so 3,100 counties approximately throughout the U.S., and we rank Appalachian counties based on 3 socioeconomic indicators: unemployment, income, and poverty, and that breaks down into what you'll see here. So there's 420 counties in the region, and we see that if we just look at the worst 10% of the national distribution, if things were proportionate in Appalachia to the rest of the country, we'd expect to see 10% of Appalachian counties in that most distressed category. But what we see is 81. So instead of 42, which is 10% of 420, we see almost twice that, with 81 Appalachian counties in that worst 10% of the national distribution. And then there's 119 in that at-risk component. So instead of having what we'd expect to see about 100 in those 2 categories, we actually see about 200 in those kind of bottom 2 categories. So it just gives you an idea of the economic distress levels throughout the region. And you can see particularly eastern Kentucky, parts of southern West Virginia, central West Virginia, and also if you glance down towards Mississippi, there's lots of counties there that are in that distress and in at-risk categories. Then moving on to kind of the first component. So again, the report kind of breaks down into three I think sub-reports. So I guess I should say that the research initiative breaks down into 3 separate reports. And the first one was the health disparities in Appalachia, which was just, okay, how is the region doing health-wise compared to the country as a whole? And so this looks at 41 distinct health measures across what we break into 9 broad health domains. So we have kind of current health status, mortality rates, morbidity, behavioral health, and kind of a generational health and healthcare. It looks at child health, healthcare systems, and quality of care, and then kind of risk factors and determinants of health, lifestyle, community characteristics, social determinants, and focusing in on mortality rates. So for each of the mortality rates examined within the region, we see that the region does worse compared to the U.S. In terms of each of these mortality rates. So for example, COPD mortality, which is just the number of deaths per 100,000 people, was 27% higher in the region than it was in the United States as a whole. For some of these other ones, injury and poisoning, which are kind of, there's some overlap there, which include overdose deaths, are much higher as well. And just a quick aside for anyone interested in overdose deaths, we have lots of information about kind of the diseases of despair and overdose death rates in the region, which are much higher than the U.S. as a whole, available at arc.gov, and we have some resources there for communities in terms of trying to combat the opioid misuse epidemic in the region. But back to these mortality rates, I think we include 7 of the 10 leading causes of death in the United States, and again, for each of those, the rates are much higher in the region than in the U.S. as a whole. And then focusing in on COPD mortality. So again, 27% higher than the national rate. We see the actual rates there, 53.5 per 100,000 people in Appalachia. And these data, I should note, are slightly dated. When we began this project back in 2014, 2015, these were the most recent data. They cover a 6-year span or a 7-year span from 2008 to 2014. And we have to do that multi-year span because confidentiality issues. You can't have single-year data for many of these, rural counties. So that's the reason for that. And then we also see that it's a particular problem in rural counties, and so the rate is much higher in the region's rural counties than in the large metro areas and small metro areas, and then also again in economically distressed counties, as we might expect, the rate is much higher there as well. And this is kind of how it breaks down. So let me jump ahead real quick. So this is how we break down the region into 5 subregions. Just kind of, you could kind of probably debate these if they fit, but this is just kind of a general sense of the region in terms of kind of cultural and socioeconomic factors. And so we have the northern, north central, central, south central, southern. And so going back to the breakdown based on those subregions, we see I think what jumps out at us is that central subregion, which again contains a lot of Kentucky, a little bit of West Virginia and Tennessee as well. So we see that that has a 78.1 per 100,000 mortality rate for COPD, which is nearly twice as high as the rate for the United States as a whole. And we also see, again, the breakdown based on the different morality designations and also the different economic statuses. And we see that there is a concentration. Central Appalachia, which is typically rural, and then also rural and economically distressed areas have the much higher COPD mortality rates. And then this is the map based on, so each of these colors designates or equates to a national quintile. So the worst, the bottom 20% or the highest 20% of COPD mortality rates are that darkest blue, and we can see that there is a disproportionate share of those high blue counties. And I'll show you the breakdown later on in the presentation in terms of just how many counties rank in those worst performing quintiles. But we see, as we'd expect, Eastern Kentucky, parts of West Virginia, even going down into Alabama, lots of counties with very high COPD mortality rates. This is the U.S. as a whole. It's kind of difficult to see based on the county outlines being black. It makes it a little dark, but you can see that even when you compare it to the region, even though there are other pockets of really of counties in that worst national quintile, Appalachia, particularly Central Appalachia, does stand out as being noticeably dark when you look at the national map. Moving on to morbidity and behavior. So I know I should have noted this before. I'm not a COPD expert, not even a health expert, but I do know that smoking is a significant risk factor for COPD, and we see that throughout the region there are more smokers percentage-wise based on population than there are in the U.S. as a whole. So 19.8% of adults in the region reported being cigarette smokers, compared to 16.3% in the United States as a whole. And just overall, you can see much worse health behaviors in the region than in the United States as a whole. And a lot of these play, are of course interrelated. So physical inactivity, you're obese, you're not feeling well. These all kind of can be, the same person can be experiencing lots of different problems that are all related to a particular health issue. So focusing on smoking, we see that again that the prevalence in the region is higher than in the United States as a whole, and then it's also, again, like COPD mortality, much higher in rural counties than in large metro counties, and also higher in distressed counties than in non-distressed counties. And again, this is distressed and non-distressed counties within the region. Again, this is the breakdown. So we see Central Appalachia again, 25.2, so that's 1 in 4 people in Central Appalachia report being cigarette smokers. Then also, again, distressed, rural counties, those are the ones where we see the higher smoking rates. Again, a map, same thing as before, where we have the darkest colors equate to the worst performance in that worst national quintile, and we see that pretty much all of Central Appalachia and most of West Virginia is in that worst national quintile in terms of smoking rates. And we see the national map again outside of, the Mississippi Delta also has lots of counties ranking in those worst performing quintiles, but still, again, Central Appalachia, parts of West Virginia are noticeably dark when compared to the rest of the country. So in terms of, kind of moving on towards health providers, why, part of the explanation for this poor health performance can certainly be prescribed to just having fewer resources available to residents throughout the region. Excuse me. So we just see fewer physicians, fewer providers, both specialty physicians and primary care physicians, and also fewer dentists. And also in terms of the residents' resources, kind of non-health related, or certainly health related, but not health specific, lower incomes, higher poverty, and a lower share of residents with some college, which is not only tied to income, but kind of health literacy and what people know about their health. So higher levels of education are associated with higher health literacy and better overall health. But one good thing about the region, and we've kind of something we like to tap into as much as we can, and we talk about it as much as we can, is there's a higher social association rate, which is a very broad term, just kind of tries to capture the social capital, social cohesiveness of a region, and we found that residents typically in Appalachia have a more I guess connectedness to their neighbors and their communities, and so that's when we're thinking about, okay, how do we tackle these issues? That's something that we talk about, and we try to employ as much as possible that spirit, so to speak. So again, this table shows the breakdown based on those national quintiles, and again, you'd hope to see 20% in each of these quintiles for Appalachia, but what you actually see is, excuse me, much higher percentages in that worst national quintile. So 39% of Appalachian counties are in the worst national quintile, as opposed to 20% for COPD deaths. And in terms of smoking, it's even higher still. So 45% are in that worst national quintile in terms of smoking prevalence. So just a quick summary, overall health disparities in Appalachia, disproportionately worse for the overwhelming majority of health performance indicators in the region than in the nation as a whole. All mortality measures are higher in Appalachia. However, these mortality rates may be affected by changeable behaviors, so things that we can start to chip away at, lower smoking rates, and therefore that could lead to lower COPD mortality, lower cancer mortality, lower heart disease mortality. However, resources are lacking, both in terms of the health resources available throughout the region, and then also the resources residents have just in terms of income and poverty rates. Employment rates are generally low, or unemployment rates are generally higher, employment lower, and again, that all ties in with kind of health, and both not just your health, but what you know about your health, and how you can tackle issues. And though improvements have been made, the region is falling further behind. I may have skipped that one, I'm not sure. So we looked at a few variables across 2 different time periods, and we saw that while the region is improving, basically from about 1990 to 2010, we looked at change over 2 decades. The region is improving in the variables we looked at. Instead of 41, we just looked at 8. But the U.S. is actually making bigger strides, so we're actually, the relative gap is actually increasing in the region compared to the United States as a whole. So once we got what was kind of a not unexpected overview of health in the region, but certainly not an inspiring overview of health in the region, we wanted to look at, okay, so what about the counties that are doing better than expected, or making the most out of what they have, and how can we learn from them? So we wanted to identify bright spots. So we have these 2 reports as part of the bright spots component. So the first is the statistical analysis that I won't get into, and then the second component is, after we identified these bright spots, we sent research teams to the community to learn about, okay, so what is going on in these communities that's making them perform better than expected in terms of health, given that they may be lacking in resources. So again, we use I'm just going to gloss over this, a regression analysis to identify the bright spots based on 19 health outcomes and 29 drivers, and we just compared, we produced these regression analyses, and we compared the actual results to the predicted results, and whoever had the highest residual across those 19 health outcomes and ranked in the top 10% of Appalachian counties, we consider them bright spots, and then out of those bright spots, we went to 10. So we went to 10 of the 42 counties identified as bright spots, and you can see here that there is some clustering going on, which kind of speaks to some findings later. So we wanted to have a kind of a geographic diversity, then also non-metro and metro counties. So these are the 10 case study counties that we went to, including Wirt County, West Virginia. And again, we sent research teams to to the counties, to the regions, to interview community leaders. And then once we got back, it wasn't just kind of a how did you feel or what do you think about it? We actually transcribed the interviews, analyzed them for themes, did some kind of qualitative research in terms of identifying what was really going on in these counties. And so we include some data with each of the case studies, but really I think the meat of it is just look at interviews with, quotes from local leaders, examples of programs that they may have implemented in these counties. So you have 10 of these case studies and key themes that emerged throughout, excuse me. I think nothing surprising, but it is, I think, good thing about research, sometimes it kind of verifies what you may be thinking, what you may know is important in your heart of hearts, but you've never seen it kind of in research. And we can say with some confidence that these 6 themes, they may not be the things that are leading to these improved health outcomes, but they were present in 10 counties that did have better than expected health outcomes. So community leaders engage in health initiatives, so basically just local stakeholders that are concerned about local residents' health, cross-sector collaboration. Again, this kind of goes back to there is a lack of resources throughout the county, throughout lots of counties throughout the region, and if you can have different programs, different resources filling holes for other programs and resources, that can lead to better overall health for a community. Again, that ties in resource sharing as well. Local healthcare providers committed to public health. So if you can have, whoever that may be, whether it's there's examples of, a couple primary care physicians that were just really concerned with their local residents' health, and went above and beyond. Then you also had employers that instituted wellness programs and benefits based on that. And then also active faith community initiatives to combat substance abuse. Often these kind of went hand in hand, where you have local churches oftentimes would have not just normal food pantry type operations, but then also have kind of substance abuse programs and support in other areas related to health. And then based on all of that, so based on both the disparities and the bright spots, we focus in on 3 particular issues that we deemed, both here at ARC and then also the research team that conducted the research, that are particularly relevant to health, overall health in the region. So obesity has so many ties to so many different health issues, opioid misuse and smoking, which smoking as well, including COPD, but also cancer, heart disease, physical inactivity, which then leads to so many other health issues. So we focus in on these 3 issues, and you can find those on healthinappalachia.org with just a quick overview of the smoking one. So we include 4 recommendations, and then also, so it's not just prevent smoking among youth. We provide examples and links and resources that stakeholders can go to and can say, many of these may not work for a particular community, but there might be 1 or 2 that do, and you can learn more about them and find out how you might be able to implement something in your particular community. And so we have that, and we also have increased access to cessation interventions, launched anti-tobacco communication campaigns, and reducing exposure to secondhand smoke. So, simple things such as having a ban about smoking in restaurants or at the workplace can have significant kind of carryover effects to the community as a whole. So again, a plug for healthinappalachia.org. I think it's a great website in terms of you can find whatever you're after. You don't have to kind of go through every page of the report, every footnote. You can focus in on your county, your health issue, and get the information that is relevant to you. So this is just kind of a couple screenshots that I was mistakenly showing earlier, and now I'm intentionally sharing. So this is just, you can go through the case studies, read about, Sequatchie County, Tennessee, if you like, or again, go to Work County in West Virginia. So these are the issue briefs. If you go up to learn more, it's kind of, that's I think the biggest flaw of the website is that the issue briefs aren't too easy to find, but you just go to learn more and then go to issue briefs, and you'll find the 3 of them there, and you can see all the different links. So there on the right, recommendation number 5. So implement community-based solutions to prevent substance misuse. So we actually have not only examples of what other counties have been doing, but then additional resources. And so you can find that for the smoking one as well. And so I just pulled up some screenshots from the data component of the website. So if you're interested in COPD mortality and you want to know particular counties and how your county is doing in terms of COPD mortality, you can do that. So here's 2 counties in West Virginia that I just kind of randomly pulled up, and you can see how their COPD mortality compares to the state they're in, their sub-region, the Appalachian region, the non-Appalachian United States, and also the United States as a whole, which is kind of a neat feature that you can play around with the data and see how your counties of interest are doing. And then here's another one for smoking throughout the region, same counties. So you can see where they rank in terms of the national quintile, again, the comparisons, and there's a bar graph at the end as well. It helps you kind of visualize where you're at. And so that's basically what I have to offer in terms of the Culture of Health project and what we did at ARC with help from the Foundation for a Healthy Kentucky, Robert Wood Johnson Foundation. It's kind of a finished product now, but we're still we're trying to get it out and into the hands of as many people as we can, because we do feel like it's a very useful resource, a live resource that people can go to and learn about different issues and learn about not just what's going on. Okay, so my community has an issue with with smoking, and I know this because the data show it, but okay, what can I start doing to maybe begin to lower that smoking prevalence in my county? So we have the resources both in terms of identifying the problem and then learning about how you can potentially start to fix that problem. That's the idea. And I'm more than happy to talk to folks about the project, about the different resources that we have available. Again, I'm not a health expert. That was Eric Stockton's role here for a few months ago. Unfortunately, he left us, but we do have some other health program leaders here. But in terms of the resources and the data behind it, I'm always more than happy to share, to talk. And I think with that, I'll open it up to questions or comments or what have you. And thanks again for the attention. Sorry about the delay at the beginning there.
Excellent. Thank you so much, Logan. That was wonderful, and that is a great resource for everybody. So what kind of questions does everybody have?
So Logan, I can start with me. I'm Sunil Sharma from West Virginia University, Women in Critical Care. First of all, thank you very much for a very insightful presentation and your work. And my question is, you provided some really important information regarding the COPD in the Appalachia. And we are aware of some of the risk factors. You mentioned smoking, which is highly prevalent in this region. My question was, have you looked at environmental exposures, specifically people working in coal mines or maybe associated in that region, whether that has an influence in a certain county, specifically the ones which you mentioned are at high risk or have much higher than the surrounding counties. So, we recognize there are other influencers of COPD, and environment is one of them, and I just wanted to get your insight on that.
No, we actually haven't looked at that directly, but I do know that there is, as you're probably aware, lots of research out there that kind of links, exposure to various, various toxins during the mining process, both in terms of coal, and then also I think there's some other stuff out there. But in terms of what ARC has done, we haven't looked at anything specifically, but we are aware that, that is also a cause of, or we would assume that based on other research, that is also a cause of kind of the higher COPD mortality throughout the region.
Yeah, and the only reason I'm wondering is because when we're comparing with the entire US, I think this is kind of unique to the Appalachia. So we need to keep that in mind, because that may be another way we can tackle the risk of increased COPD mortality. Yeah, thank you for the insight.
No, thank you.
No worries. Thank you. See you later.
You too. Sorry, I gotta run.
No worries. Other questions, you guys?
This is Lee Petzong.
Great.
Sorry, go ahead. Go ahead.
Go for it. It's a little bit of feedback. Sorry, Dr. Petzong.
No, I just you're probably, Logan, aware that we did some GIS studies of we looked at disease prevalence, and we found both COPD and pneumoconiosis were highly associated with the Central Appalachian coal mining, and I wonder if was there any reason why, when you designed this study, you decided to not look at something which is sort of clearly going to be a driver of both the health behaviors and the health, and that is these the economic patterns of the region.
Well, I'll start off by saying I wasn't actually around at ARC when this project was first designed, so I can't speak to kind of the formulation of it. My guess would be that we are inherently a political organization at times, and we kind of steer away from some things that may upset industries, and I don't mean that we steer away from contentious issues, but we try to keep things broad, and if we release the data, and if people can then make connections based on that with particular industries, which I think other research has, other researchers can do that. And again, this project started back during 2014, so it's just kind of in the back of our heads. That's always kind of a concern if we're gonna seem as if we're talking down to counties that have particular industry specializations and focuses, but that's not to say that we're not aware that it is an issue. So I know it's kind of skirting the question. I apologize, but one, I wasn't around, so I'm not sure. I can't really speak to the decision to keep that out, but I do think that may not fit in this particular project just based on, social determinants are very broad. So those are things that we can measure across the entire region, whereas kind of the industry focus on coal mining in particular would kind of seem like we could be targeting, particular subregions. So I think that may have played a role at the time. So I apologize, I can't really offer a whole lot there, but that would be my kind of guess as to why we kind of steer clear from that.
So you're more or less saying that there was a political decision?
No, that's I mean, first I will say again that this was started in 2014, so it was a different administration, different appointee, and so I don't think that the co-chair at the time had any say on that, but I think we're focusing in on the health issues that we can identify as being health issues and the social determinants that have been proven to be determinants of health. And so we try to keep this broad. So when we release something that we can focus on the health and we can focus on the social determinants, and we don't have this a headline grabbing type talking point based on a particular industry. So I think it was probably a good decision. And again, the data are out there. So if people want to make connections and perform their own research connecting these things, but there would just be too many things. So so you have, certainly coal mining may have been, in other research may have been found to increase COPD, but there are lots of other environmental hazards, lots of other industries with risks. And so if we try to include each and every one of those, I think we get weighted down with kind of those talking points and those issues. And so we try to keep it broad and try to keep it as kind of, I think informative as possible in terms of kind of those higher level findings, and then researchers with more experience and with kind of a better feel of the particular issues, they can kind of dig deeper on those particular issues. And I think Eric may have wanted to say something.
Yes. Thank you, Logan. Good job and great to hear your voice. And Lee, I was around when the study was being designed, and part of what was happening at the time was we had to manage the scale of the effort based on the resources we had. And even though this was pretty much the largest research project that ARC was ever involved in, we still couldn't include all of the measures that we might have included just because we had to draw the line somewhere. And the disparity study was based on 42 measures, which was a lot. And so there were several measures that we couldn't include. We didn't really, at the time, I was really interested in and concerned about hepatitis. And that's an example of a measure where we couldn't secure enough county level data or good data on some measures to include them in the study. I'd say also at that time, COPD and lung disease was not particularly on our radar. And personally, I was shocked when I was at ARC to know about the extent of COPD issues in the region, and it was a disease I didn't really know anything about. So we didn't have an outlook of particularly zeroing in on some of the risk factors for COPD versus any other health condition that was included in the mix. So I do think it was always our intention with Robert Wood Johnson at the beginning that to some extent the project would be a departure point for other researchers. And I think, as Logan said, the data is there and could be used as a foundation for further work. So I think knowing the prevalence of COPD and the geographic layout of the disease could suggest additional research questions that need to be covered by somebody who is more equipped or has the resources or ability to try to overlay those industry clusters with the health conditions, also with updated data. I think it'd be a great research project for somebody to do. So, just wanted to back up Logan there on how the program was designed when we set it up when I was at ARC.
Thank you. Dean and Caitlin, did you guys have a question or something before? Go ahead and unmute.
When you were doing your bright spots, or what was the, like if you want to become a bright spot, what were the biggest drivers in those communities that pushed that?
Yeah, so there were actually,
Sorry, it's just
yeah, so no, sorry about that. So there were a few of the variables that that jumped out. Let me pull up the results here. But there were what we call 7 high impact drivers, and then also specific outcomes that were correlated. So if you did well in these specific outcomes, your overall health in those counties was better. And those 3 were just kind of broad premature mortality, which I don't think tells us a whole lot. But then also unintentional injury mortality and poisoning mortality, which are basically overdose rates. So a lot of these counties had substance abuse initiatives to tackle the opioid misuse going on throughout the region. And so we found that communities that had very active and strong programs and resources dedicated to opioid misuse had better overall health. And I think it may be kind of important to know that these case study visits took place a couple years ago, and though there was a lot of attention given to the opioid misuse epidemic at that time, I think it's only increased since then. So so these communities lots of times already had resources in place, and so it kind of speaks to kind of maybe the focus of those communities that have in terms of just kind of the health issues that they were aware, they were kind of forward thinking in terms of, okay, we know this is going to be an issue, and they had systems in place. that's kind of one theory behind it. And then also, there were 7 high impact drivers. So these were, so these drivers predicted the most variation in those health outcomes. And some of those are what we'd expect, but we have median income, and then poverty rates. So, you know, kind of a no doubt, but then also some health behaviors were percentage of adults who smoke, percentage of adults who are physically inactive, the percent of the population receiving disability, then also teen birth rates. So in kind of those four areas, you could, those are kind of changeable behaviors. So smoking, physical inactivity. So those are areas counties could easily, probably, you know, not the right word, but, you know, a lot of programs that don't require too many resources in terms of trying to get anti-smoking campaigns going, and also kind of physical and you know, getting adults physically active, and then also kind of the teen birth rates thing. I think there can be there's lots of opportunities there. So those kind of the anti kind of, or the opioid misuse resources, the targeting there, which kind of is indicative of communities that are kind of forward thinking and are aware of the issues in the region and are proactive in terms of dedicating resources to combating those. And then also those other kind of, I think, kind of evergreen health issues in communities, which are the smoking and the physical inactivity. These counties had typically had lower rates of those that led to better overall health. So I'm not sure if that entirely answered your question, but there is kind of a nice write-up on healthinappalachia.org in terms of, well, if you don't want to read all the case studies, which I don't blame you, there's 10 of them and they're long, but you can kind of read the high-level findings in terms of, okay, so these are the general characteristics of these counties that overall they may be lacking in resources, but they're doing better than expected in terms of those health outcomes.
Dean, did that answer your question?
Yes, yeah, that's good enough. Thank you.
Great, thank you. All right, guys, we have about 10 minutes. Were there any other questions? Logan, I was going to ask, is there any plans to follow up with this, to do a new, I don't know, round of data collection?
As of right now, no, there is not. I would love to see that come to fruition because, again, the data are already outdated. To some extent, I think a lot of this, you know, the findings and, you know, kind of the patterns are gonna hold true even today and then even in the future. But an update would be great. Unfortunately, we're a small organization and it was a significant undertaking, which again kind of speaks to what Eric was talking about earlier. We only had so many resources dedicated to only so many resources we could dedicate to the project, so we couldn't look at every potential health issue, particular health issue. And again, I want to know, because I'm feeling a little uneasy about the comment earlier, that, you know, it was never a conscious decision to say, hey, we're not going to look at something. That's never a conversation that's had here, and if it has been had, I haven't been aware of it. But we're just we're aware of our resources and our bandwidth, and we can't look at everything. And if there are particular issues that we're not sure of, and we don't want to come down on ones that we just can't. That's not the best use of ARC research funding and resources. And so we provide data, and we provide kind of the resources that communities can then use to, and researchers can use to then you know, can perform their own research, draw their own correlations to particular industries, what have you, other environmental factors. But it was never a conscious or a decision point to say, no, we're not going to look at something or another. It's just kind of the reality of being a small organization. There are 2 researchers on staff. I'm one of them, and so we can't look at. So we contract out a lot of the work, actually. So that's just kind of circling back to that. But to answer your question again, Caitlin, if I haven't, is that I don't know of any plans in the near future of doing so, but I think it is one of those, that I do think we might circle back around to in a couple years when there are maybe another couple years between the data that we're using in the report and then what would be available then. Then we could also look at, how things have changed over that time. So I think it would be a very useful thing to do. It's just a matter of what we have the resources and what we have the interest and the time to do so. So stay tuned. As of now, no, but hopefully at some point, yeah.
Sure, certainly. I understand. I was actually looking at the website while we sat here, and it's great. It's a great resource for people. We do a lot of grant writing here, so I can definitely see it being used to pull that data for that. Eric, you want to?
Yeah, I would. Yeah, maybe to echo that, Caitlin, and also some of Logan's comments. Some of the utility I see for these tools for, anybody out in the communities at, a clinic or hospital or academics as well. But I think the healthinappalachia.org site gives you some great tools if you want to be thinking about programs to implement related to COPD and lung health. If you're pursuing resources from, your board, your county commissioners, your state organizations, your private funders and foundations, if you can be data oriented as you pursue those resources, you're going to be in a better position to get the money that you need to implement programs that will make a difference. So the tool really gives you a great ability to be really specific about what problems are facing your target population, your community, and help you tailor a response that is really data driven. And funders really like that. So instead of being in a position to say, hey, we really think we ought to work on COPD risk factors, you can back that up with really hard numbers about the counties that you serve and make it clear that you know what you're talking about. So I hope that everybody could make use of that tool to, as you think about programs you want to implement, and design them and pursue the resources that you need.
I totally agree. And everybody out there, I know you guys are all at rural places, but I and Mitra now are always happy to help. If you would want information found, we're happy to go ahead and pull that for you and stuff like that. So just let us know. Any other questions? We have about 5 minutes left. It's been a great discussion, and Logan, I want to thank you again for that. That was wonderful, and I really appreciate everybody talking and asking questions. All right, great. So our next session is going to be December 2nd. We should have a case from New River Health. If not, I will, of course, be pleading with everybody to send in a case so we can discuss something. And that is it. You guys will hear from us again soon, and everybody have a happy holiday season.
Thank you.
All right. Thanks again, Caitlin. Thanks, everybody. And feel free to contact me, lthomas@arc.gov. Happy to chat about this and help in any way. Thanks, guys.
Thanks, Logan.